Good morning, everyone. I'm waiting for my slides to come on and get started. So it's a real privilege for me to be presenting the outcome of the CAPRISA 007 results, the match pair cluster randomized controlled trial on behalf of the study team. Now, I've been very nervous coming in this morning because last night when I did a presentation, my slides disappeared. Oh, thank you very much.
You're welcome.
I was like, okay, last night I could work without slides, but today you really do need to see the slides. So conditional cash incentives have been effective for a range of behaviors such as smoking cessation, vaccination uptake, and drug rehabilitation. Recently, we've seen a growing body of data that's very promising, showing that incentives may reduce risky sexual behaviors and impact HIV transmission. I think it's important to think about this novel strategy in relation to the ongoing high HSV-2 and HIV rates, notably in adolescent girls in Africa, with very few prevention options for them to take control of their own risk. And you can glean some indication of the severity and magnitude of the difference between young boys and young girls from the baseline data from this study. And you can see in the top half of the slide that HIV infection is fairly low in young boys, under 2% between ages 15 and just over 20. In contrast, in women, we see already by age 15 an HIV prevalence of 2.6, increasing steadily with age to about 1 in 10 by age 19. Although we see more HSV-2 infection in young men compared to HIV, increasing with age, if we look at the HSV-2 data in young women, we see, again, substantially higher rates of HSV-2 infection in young women, about 3 times higher for those young women under 15, and steadily increasing to 43% for women over 20 in these schools. The purpose of this study was to assess the impact of conditional cash incentives on the incidence of HIV and HSV-2 infection in rural high school students in South Africa. 14 schools were matched as 7 pairs by school enrollment, size, geographical proximity, and school pass rates. A total of 3,217 students in grades 9 and 10 were enrolled with parental consent and/or student consent or assent as appropriate. HIV and HSV-2 testing was done serologically with commercially available kits at baseline, 12 months, and 24 months. In parentheses, I provide the retention rates at 12 and 24 months. The baseline HSV-2 prevalence and HIV prevalence was slightly higher in the intervention arm at baseline compared to the control, and you can see that 9 and 4.7% respectively for HSV-2 and HIV in the intervention arm compared to 7.3 and 3.7 in the control arm. The intent to treat analysis was performed at the cluster level using paired t-tests. So I'll go through the consort diagram very quickly. We enrolled and randomized 2,949 students at 14 schools, 1,447 in the intervention arm, 1,502 in the control arm. And key reasons for exclusion from the 3,864 volunteers was absenteeism or already being HSV-2 infected at baseline. 1,330 learners and 1,386 in the control and intervention arms completed follow-up. And the reasons for loss of follow-up from enrollment to completion of study are very similar in both arms. So in terms of the intervention, all 14 rural schools participated in a local life skills program called My Life, My Future that included HIV education. 1 school in each of the 7 pairs were randomly assigned to receive, in addition, cash incentives for any combination of 4 conditions being met. And these included 80% quarterly participation in the life skills program, attaining a passing score in 6 monthly academic tests, and undertaking an annual HIV test, and finally submitting a report on the community project at the end of the intervention. The maximum possible amount of cash that any student could receive if they met all of these conditionalities was 1,750 rands, which in terms of US dollars to rands is about 1 to 10, about $175, which is about equivalent to half the local childcare grant. So in this table, I provide you with some breakdown of each of the conditionalities and the attainment achieved in the intervention and control group. And what you can see from this table is that most of the cash incentives were for HIV testing and the life skills program attendance. We had very little impact on school performance and few completed the report. And I'll come back to unpacking the school performance issue. I'm going to move on to the cluster randomized analysis, and in terms of the effectiveness on HSV-2 infection, we had 136 events in the intervention group and 183 in the control group, yielding an incidence rate of 6.2 per 100 person years of follow-up in the intervention arm and 8.7 in the control arm. The incidence rate ratio for HSV-2 was 0.7 and was statistically significant. On the HIV incidence, we had 1.8 per 100 person years of follow-up and an incidence rate of 1.5 in the control arm. And basically, we had too few HIV infections, a total of 75, to really assess the impact of HIV in the study. Overall, what we can see is a 30% lower incidence rate of HSV-2 with cash incentives. So if we do this analysis at an individual level, and here I present the Kaplan-Meier survival probability for HSV-2 and HIV infection. The HSV-2 curves are on the upper part of this figure, and the HIV on the lower. And what we see is at 12 months, we have a 28% reduction in HSV-2 infection, and that increases to 30% at 24 months. And so the effect size that we're seeing is very similar to the cluster randomized analysis. I'm going to move on now to some subgroup analysis. And before I break down the cash incentives in categories, I just wanted to flag that the conditional cash incentives had a 40% lower HSV-2 incidence rate in boys compared to 24% in young girls. If we take the cash incentives and break them down into less than $65, $65 to $95, and more than $95, and compare the HSV-2 incidence rate to that in the control arm, what we see is a steady increase in the potency of reduction in HSV-2 incidence rate with increasing cash. And students who got more than $95 had a 71% lower HSV-2 incidence rate overall in these three categories. We had too few HIV endpoints for any HIV subgroup analyses due to the lower than expected HIV incidence rates. So if we wanted to do an analysis with the HIV infections similar to that with the HSV-2, we would need a sample size about 3 to 5 times larger to provide adequate power to assess 30% impact on HIV prevention. So we're really talking about studies in the range of 15 to 20,000 individuals. To conclude, cash incentives was associated with a 30% reduction in HSV-2 incidence rate. And it's really important for us to think about context and how does context in relation to cash incentives play out. So this study was undertaken in one of the poorest rural communities in South Africa that also has the highest burden of HIV infection. Less than a third of the conditions were met, so we had a median of about $60. Cash incentives for school performance made little impact, and we have to appreciate that school performance is made up of multiple facets. It's not just what the kids do, but it's also what is the quality of the schools, what is the quality of the teaching, access to textbooks, and a whole range of issues that come into play, including school attendance. What we have seen is that the cash incentives made the impact on the HIV-specific conditionalities, notably the uptake of HIV testing and the life skills program attendance. And I would caution the interpretation of the dose response. This is a subgroup analysis, and we need to look at that with a pinch of salt. The study could not establish the impact of cash incentives on HIV infection due to the statistical power being lower than expected, and this could be due to a number of factors, including a general trend of lowering of HIV incidence rates in this community, a number of community interventions being introduced during the course of the study, including treatment programs, microbicide trials, and the introduction of medical male circumcision. And it's also possible that the study-related interventions may have impacted the HIV incidence rates. The bottom line is that structural interventions in the real world are very challenging and very complex. I'd like to conclude by acknowledging a number of people who've contributed to enabling this study to take place, and these include the departments of education, the school governing boards, the students who participated in the study, as well as the staff from the schools, our partner, MIET Africa, the CAPRISA 007 team, and this study would not have been possible without funding from the Embassy of the Kingdom of Netherlands under activity number 20336 as a subcontract with MIET Africa. I thank you for your attention.
Many thanks to